Hey, Chris, how are you?
Hey, good, PK. How are you doing?
Well, thank you so much. And I want to thank on behalf of all of us here, your team for really, doing this on a Saturday. We know how hard you guys work during the week. And we really, really want to thank you and your team for waking up on a Saturday and doing this wonderful presentations for us. Thank you.
Oh, it's our pleasure. We're honored, PK, to be transmitting live from Kingsport, Tennessee. So welcome. You want to tell me who's on the panel there?
I was just going to introduce our team
in case.
Yeah, we've got a great panel of all your old friends. We got Nick Shamus, we've got Art Lee, we've got Vishal Kapoor, Sahil Parikh, and we've got Mahmood Razavi. Dr. Faries and Dr. Saab may be joining us. I'm not certain if they're here yet, but that's the panel for you.
Wonderful. Well, if it's okay, PK, let me introduce our team. Honestly, it's been one of those nights where we've had two STEMIs. I'm actually on STEMI and vascular call, but I have a partner, Gaurav Rana, who's helping me out. As you say, during a pandemic and on Saturdays with hospital scheduling, these are great folks who have really, really worked hard. We had to do a little readjusting, and you're going to get to watch me struggle a little bit, but you're going to help me through that, and I'm confident with that panel we're going to get through it. So let me introduce my team first. The hardest job on the table is keeping a smile and working with me all morning is Alexis Mullen. Again, she's only been here a little more than a year, PK, and as you know, it's very rare that you get somebody live case ready in their first year. Alexis is one of them. So thank you, Alexis. Behind us, we have the nursing talents of Allie Gray, and we have Michelle. We have industry support as well, Jordan and others. And in the back, behind the scenes, are Oksana Leeper and Sydney Ward. So thank you all. And again, we're thrilled to be here. And again, congratulations, PK, on pulling this meeting off. And again, really look forward to an ongoing collaboration with you. It's an honor.
Well,
so let's show our slides here, please. Next slide. So here are my disclosures. Next slide. All right, this is a very nice lady. It's kind of a last-minute film because of some other things, but boy, it's appropriate. No known coronary disease. You see the risk factors there. And I had actually seen her in March with severe bilateral carotid disease. She also had very significant claudication, but at that time, PK had no CLI. I had recommended carotid angiograms and revascularization and workup of her peripheral vascular disease. But this is a wonderful, wonderful lady who is dedicated to her husband who had been in the hospital for a while. She had to get him out of rehab and literally said, I can't deal with this COVID-19 rehab and not being able to see him. So she brought him back and literally nursed him back to health. He had lost 57 pounds. She said, Chris, I love you, but when my husband's better, I'll come back. All right. So we deferred the workup and put her on optimized medical therapy. Next slide. Next slide. There we go. Now, in helping her husband going up and down the stairs, again, you can't make this up, just beautiful people, she fell, injuring her right shin. Initially, it was just felt to be a superficial injury, but she had a very deep ulcer, which I'll show you in just a second. And then her claudication worsened as she's doing all things at home at very short walking distances bilaterally. On the right, you see her ABI and TBI monophasic signals. In the CT angiogram, I'll show you some images. This was done at another facility, so I could just take some snapshots. But you'll see an occlusion of the pop, high-grade calcific disease in the SFA and pop, and some tibial disease. And then so she was brought in to fix that and had to come in a little earlier because the wound got a little worse. Next slide, please. All right, here's just some pictures, and you can see on the axial images in the middle, just a complete dense chunk ball of calcium there, and then a couple representative images of the calcium. Okay, next slide. Here's one picture of a wound. What doesn't transmit there is the rubor in her right foot. Okay, next slide. Here are some juicy carotids. I did everything I could yesterday to keep my hands off of them, and for now, until we finish the business at hand. There's her right. Next. And equally ready for a carotid research trial is the left. Next. All right, so let's come to our fluoro here, PK, and show you what we've done so far. And by the way, thank you for these hats. These are absolutely the best hats we've ever had. And the nice thing is they have a little brow in there. I never sweat, PK, but I almost started to sweat here, and this wiped it up. So we appreciate these cool hats. All right, so let's go to our, all right, so micropuncture access on the left, as we always do, and I'm sure you do as well. There's a left renal that will have a future date, potentially, but not needed now. and really no iliac disease. And we just use that as a smart map, as a lot of us do, go down into the profunda and up and around with a 7 French Ansel. Here are images. You see the hip replacement now. It's very severe there.
Wow.
And then lots of serpiginous, geniculate type of collaterals. Very delayed filling of the AT. And you can see that it looks like the perineal goes off and gives a posterior tibial almost as a continuous vessel. Okay? I'll let that play again, and then I'll show you a couple of oblique pictures. All right, here's a subtracted oblique picture. You see lots of branches there, lots of recanalization and microchannels. And then you can see it does, when it reconstitutes there, there's bad disease in that long, small caliber distal popliteal artery before that bifurcation. Okay? All right. So why don't I stop for a moment and just ask the panel a couple things. Would you go antegrade? Would you go retrograde? Would you go both? Would you try antegrade and then go retrograde? And then what are some of your strategies? And I'll show you what we've done, and we'll get to work here as we need to. So
yeah,
just a
so
quick
you
opinion or two.
you have a lot of people who can help. I mean, Art, what do you think?
Yeah, I mean, I think the great thing is that she has very good sized vessels, even distally, and good reconstitution points. So where the disease is bad is calcified. So I would probably do what you did, go up and over. I'd probably probe the anterior cap, the antegrade cap, and with an 035 angled catheter with a prolapse wire, and see if I can stay in. But I wouldn't go too far, and you don't want to dissect the where it reconstitutes. There's going to be disease there. So I would go very quickly to retrograde to at least cross. And then again, I'll probably deliver therapy from above once we crossed.
So Chris, I wanted to ask Mahmoud. Mahmoud, I mean, when you look at those collaterals coming antegrade, I mean, would this be something where you would try to do a retrograde cross and then fix antegrade rather than mess with those collaterals going forward? Although definitely what Art says in his hands and experience is good. But if you were a less experienced operator, I mean, would it be better to try retrograde because of the favorability of crossing, or no?
I mean, that's a great question, PK. I would do the same thing as Chris and Don and Art suggested, that go antegrade first. Knowing that at the end of the day we will be able to recanalize, and hopefully those collaterals, the collateral right there that you can see, are going to be decompressed. So this, in my opinion, is probably going to be faster if you go antegrade and retrograde. There's no doubt that you could do this antegrade without going retrograde, but it's just going to take longer, in my opinion.
Okay.
Right.
So, Chris, you got the
just,
advice.
Yeah. So I do, and I love Mahmoud's confidence, and I have the same. And I said, there's no doubt you can do this antegrade. And I'll tell you my thought. I thought we exactly like both Art and Mahmoud said. If you look at that disease I have on your picture there, usually retrograde, you've got a nice cap, and once you cross a retrograde cap, you're almost home free. You can just push. If you look at all the disease there and that recanalized stuff on the picture in the antegrade fashion, it's no gimme that once you cross a retrograde cap, you're going to get not subintimal in that. And I really thought that we could get into all those correct channels there and get down to that beak that you see at the bottom of the screen in an antegrade fashion. And like Mahmoud said, there's no doubt. And Alexis looked at me and said, "Come on, dude, get across that antegrade. Let's please get to work." All right. Well, let me show you what dude did or didn't do. So you see that picture there. We did go up and around, just a road map here, and then carefully made some angulated road maps to lay that out. Here you can see the wire is there, but if you look at this, it's going into that channel. So the nice thing is you change your angles a little bit. When it kept going into that geniculate, we changed the angles again. And here we've got a wire down to that beak. This is a Command 014 with a 018 Navitas. Okay. So now we're right down to that beak, and you can see that distal beak there. Now, here we go. See those two beaks, and they're asking. I mean, PK, they're calling me. They're saying, "Chris, here's beak 1, here's beak 2. It's Saturday morning." Well, I could tell you the beaks weren't playing nicely. So very careful manipulation down here, and you can see the way that wire's behaving.
Yeah.
or misbehaving would be probably the better word. See that?
Yep.
And the last thing I'm going to do is inject in there. So we had a little blood return, but nothing good. And I put a 014, you just try to steer it. And the bottom line is it just is not in the right place. And we tried to readjust a little bit. And as was said, I think very astutely earlier, the last thing you want to do is take that dissection distally. So at this point, would you go retrograde?
Yeah, I mean, let's ask Sahil. I mean, what do you think, Sahil? When do you give up going integrate and go back retrograde?
I think it's all about the feel. And I think Chris has demonstrated that he's suboptimal from an integrate approach. And, sometimes you can pull back and rewire, but the retrograde approach is going to be more expeditious probably. And it looks like that's what he did.
And Nick, I know you have a lecture on this, but I mean, before you get to your lecture, you might as well ask you about imaging. I mean, would IVUS or anything like that help? I know the Japanese have done so much work with that, and so have you. Does that help in this area to find the right cap?
I think you need to cross first to really, at this point, you're not even beyond the initial cap. So I'm not sure how much imaging is going to add. I think you need to try to get your wire through. And if you're suspecting that you're not in the lumen, then probably putting the IVUS will help you out at this point.
So
right now we're not there yet.
But you haven't used IVUS to try to cross these CTOs?
No.
Okay. Oh, that's interesting. How about anyone in the panel? Anybody who's using imaging to identify the caps? I didn't. Okay, great. So Chris, which wire did you go? I saw you got retrograde access. Which wire are you using?
So we have a V18 short taper right now. And we're going to be very careful here. And I figured I'd wait for you guys for this. And this is where, PK, if we struggle too much, feel free to go to a lecture at any time. Or now, first, what I would do is coach me with some good words of wisdom and then leave me alone and then come back. We'll figure this out. All right. So here's a V18 wire.
Sometimes these small occlusions can be a real pain in the neck because of the calcification.
Honestly, PK, I have a live case rule that you may follow as well. The last thing to do in general is to take a shorter CTO because everybody thinks, come on, they're that big. Come for crying out loud, get across it. They're actually harder. Now, when you do these long ones that flies across, everybody thinks, oh, wow, Chris and Alexis are amazing. So I violated my rule, but we had to do that. So anyhow, let me get to work here. We're going to go up very carefully. I'm going to bring the...
Chris, this is Mahmoud. Are you sure you're in the right channel coming from below?
I believe I am. But it's a good question. I saw I think so, buddy. Now let me try to show you up there.
Oh, there you go.
Oh, no.
Not show you up, but I mean show you what I mean. I'm hoping that's in a good spot. Now what I'm going to have to do, I remember I was across with the other catheter. When I say across nowhere good. So I think the best thing to do is to come back a little bit with the other catheter from above. Now, if we get through this, start thinking, team, what we're going to do in terms of how we're going to get an antegrade wire there. I have some ideas, but I'm always, and I don't like the way those wires are not really
close by. Chris, what's your support catheter for below?
So all it is right now, PK, and again, illustrating the panels here, I just have an 018 Navicross bareback. We've got a slender sheath if we need one. Let's take a look and get an idea where we are.
Art,
hey guys,
you do
can
a
you
lot
all
of pedal work? And I'm just going to ask Art, how often are you putting sheets in the pedal, Art? Are you just using it to cross?
Get a little
I tend to put sheets in 95% of the time, but I use a Cook pedal sheath, 2.9 French, so it's really small. Once in a while, I'll use just a 018 CXI bareback. But most of the time I start there, I cross, and I only upsize if I'm comfortable with the size of the vessel and if I need to. Most of the time I cross and I bring everything back the other way.
Gotcha.
Oh, that's not a happy picture, but we'll make it happier here, hopefully. And sometimes I think when you have the catheter across a microchannel, you actually block the flow. So I may have to just pull the, make sure I'm pushing right wire.
So Vishal, when do you decide to upgrade your wires? I mean, here, Chris, I believe you're going with two hydrophilic wires. One is an 018, one is an 014. I'm curious, when do you guys go to more CTO tip wires?
Well, I guess, in this case, like you see, they started with an 014 from the top. Of course, he didn't want to be very aggressive enough, but slowly, especially the calcification, which is a big limiting factor here, you might have to go a little bit more aggressive and go to your 035 system if it really didn't cross over. But because now we have bilateral, approaches, I think it'll be more about how the two wires meet, puncturing through the intimal plane and trying to catch one with the other. But if it's only one-way access, then once you start losing your feel of the open force not making any headway, then you can be aggressive and switch to your 035 glide system if you use it.
Anybody else in the panel with a different approach?
No, I think the only advantage of a more aggressive wire is that the non-jacketed wires do tend to give you a little more tactile feedback.
Right.
So, for example, a Confianza Pro 12, something we might use in a coronary CTO, even though it's 14, will probably give you a little bit more puncture power and tactile feel.
Yeah, I may use a CTO wire right here just for a little bit with a hook bend and see if I can re-enter. But most of the time, 90% of the time when I use a V18, I'm using it to prolapse and dissect up anyway.
Right, yeah.
If it doesn't go smoothly, I'm dissecting up and double balloon fenestration or something getting across.
Nick, yourself?
You got it.
I'm not sure how much having a high tip, crossing wire will help you in that situation when you really need to at least know you're using it against a cap of some sort or something like this you want to cross. But right now you're probably in a subintimal space. I'm not sure how much is going to help you at that setting.
So Chris, what type of tactile feedback are you getting? Is it very calcific or?
Yeah, it's not friendly. It's calcified. It's not. There's not a good thing I can say. It's kind of got the Halloween feel to it. A little early, so we're going to come back and come at a different spot here.
So Chris, if you don't mind, we're going to let you work a little bit, and then Nick's going to give a talk on the role of imaging. We're going to watch you on the side of the screen. So keep working.
PK,
and
let me ask you something before you leave.
Yep.
At this point, my initial plan was with all this calcium to do CSI if we stayed in the true lumen.
Right.
What does the panel think about a cart technique here from above and below if we're very close, and then shifting to a shockwave and another strategy?
That's Chris, it's Sahil. I completely agree. Now that I've had a lot more experience with shockwave, when I'm deeply subintimal, I don't use atheroablative techniques really anymore. Shockwave is really safe and does a good job at giving you vessel expansion. I think
I totally agree too. Anybody in the CSI and the subintimal plane, at least in Sinai, we try to avoid it. Has anybody had experience with that, or has everybody agreed that it should not be done usually?
Try to avoid it.
Yeah.
We do it more than you realize, though. I'm sure.
We do it
a lot. So I think it's still safe.
Yeah.
We downsize the crown a lot when we're subintimal, but if you're very subintimal, I think shockwave definitely, if you have it available, is a much better alternative.
So Chris, you heard the IVUS talk. Any thoughts on imaging, or right now, where are you?
The only image I see is the one that's not showing the wire and lumen yet, although I agree with everything that Nick said. I think in the coronary world and in the peripheral world, there's absolutely no question that IVUS is invaluable, and we always undersize stents. In fact, the best way to become a good stenter is to IVUS. Now, after 10 years of IVUSing, maybe you don't need it every time, but for younger operators, especially cardiologists, I think that it's almost, you have to do it because we'll realize, now, let me back that up very carefully, leaving that wire there. I think it's invaluable. Okay, you got that out. All right. So let's think together here. What we're going to do right now, I couldn't cross from either way, and I've tried for a little while with several wires. The question now is, should we cart? If we cart and externalize, it's now changed our therapy completely from CSI to probably shockwave and then DCB plus minus Supera interwoven stenting. So let's have our 018 balloon, the bigger balloon from above, the 4060. Now, any concerns that the panel has about carting in two subintimal spaces with this much calcium?
Anybody? No, it looks like everybody's saying no.
It just, as you know, calcium is always a surrogate endpoint for potential failure.
Right.
With these, but you got to do something here. The cart is probably the way to go.
Well, I just wanted to ask the panel, Chris, as you get the cart ready, how often are you guys using reentry devices in these kind of cases? Obviously, reentry devices are there. You can use needle technology, whatever it is, your flavor that you like. I'm just curious.
It's pretty infrequent nowadays. With the advent of retrograde, it's both cheaper and often faster to go retrograde and do something like this, either a catheter strategy or a balloon strategy or a double balloon strategy.
Anybody different?
No.
Yeah, I mean, very rarely now, but sometimes runoff. If it's just a single vessel peroneal runoff, sometimes we'll do reentry for depending on if they're claudic and so on and so forth too.
Right. Just it depends on the scenario. But I think in this type of calcium is going to be very difficult even with reentry. In order to actually, sometimes your Outback or your Pioneer is going to bounce off the calcium. It's going to be very difficult.
And I guess and I guess the biggest issue is the distal reconstitution and the collaterals that supply it. So if you enter into a plane and you destroy your collateral, which is feeding the distal vessel, then the re-entry becomes a little bit tricky. You don't want to re-enter and just close off your collaterals for the future. Okay. So I think that's one thing you have to consider before you start getting aggressive enough and using a re-entry as a device. So,
Chris, could you go through some of the balloons that you've chosen?
Yeah, I chose what I had on the shelf, which we have Armada 018s, because that 018 wires in is the last one. So we've got an Armada 018 4x60 from above. It's a good balloon. It's not always is 100% trackable. And you can see at the top, we kind of reached a point where we couldn't get to our reentry, but we are there from below. From below, we're going to go with a 3.540 Armada 018 over this 018 balloon bareback. Although I'm going to have a low threshold pretty soon to go with Art's slender sheath idea here, because we may start getting into some issues here. In fact, let's go and go here since we
what size slender sheath do you have in the feet? Is it 5.6? Is it
4/5?
Yeah,
we have both actually.
So just from a technical standpoint, let me just tell you what I do when I do this. So if you're going to use a CTO wire, going back earlier, the time to use is before you make some big dissections with the wire. So because you really want that tight space to try to penetrate. Okay. Once you do this, I tend to, you want to make multiple angulations, because the wires look on top of each other here, but you go an orthogonal view, and you want to make sure they're not totally off, like really far away. Amen. So you want to make sure they're close.
I couldn't agree, and we're going to do that. And guys, you good? Okay. If worse comes to worse, I've got an ego, but I'm a short guy, so my ego is kind of short to go with it. I don't mind if we have to not rush it and not do something bad, to say, we're going to show you a bunch of techniques and it's not going to work today, but we're going to try not to do that. All right, so let's do this. Let's go with Art. Let's hook up both balloons. And what we're going to do, Art, I could not agree more. Sometimes in the AP, we think, oh, gosh, that's golden. And then you go one view, another view. It's the same when we use a reentry device. You realize I'm not that close. We need another interface. So we'll look at that. Go forward. So back to the reentry. Go ahead.
You went with a 4 from above. Just for the audience from below, what balloon did you choose?
3.5.
3.5, okay.
So I think
it was kind of an availability. We have a whole list of Armada 014s, not as many 018s, and that's my fault, not Abbott's fault. And because I have 018 wires, the staff was smart enough to say, hey, I'm not going to give you an Armada 014 balloon. So that's the good thing about having good staff. Back to the reentry thing. Even if we do use the reentry, we would have to balloon this just to get it down there. Yeah. And I'm not sure I wouldn't use the ultrasound assisted. We may use the balloon in a different capacity, meaning that if the cart doesn't work, we'll use the Outback, which we have back there, to puncture the balloon from below and just pull it out as we need to. But Art, this is getting a little better, although they're off to the side here. Let's take...
But you have a good overlap there, Chris. It looks like, at least from my old eyes here.
Yeah, and the good thing with calcium in the vessels, you can see that you're sort of within the confines of the adventitia with the calcification, probably.
Yep.
I've seen this vary, by operator, on the size of the balloons and also how much overlap. I tend to overlap less initially, and I size the balloons pretty aggressively. So if I'm in an SFA, I use 5 and 6s. In a tibial, I sort of right size, as I call it. So basically, I go by the size of the vessel minus 1 maybe. And I do less overlap. Yeah. If that doesn't work initially, I get more aggressive and I start overlapping more and moving it up more proximally and just trying to rip it to make some communication.
Mm-hmm. The other thing also, what we do is we do the same thing as you. We keep the shoulders of the balloon is what we try to overlap initially.
Yeah.
And then see how it works. But definitely with the sizing, we're a little bit bigger.
All right. So here, guys, I want to get in position first to make sure we're okay. Here's our shoulder to shoulder. There's the upper end of that balloon. Lower end of that balloon. Are you good with that shoulder to shoulder position?
I think it looks great.
Good. Yeah. Okay, let's go. Now yours is, I'm up here. Okay.
Now for the audience, you can see that he's got the wires very close to one another. So they're actually the subintimal plane next to one another. And what Dr. Metzger is trying to do is break the septum between the plane and allow one of the wires to go through. Now you could
Now,
do
they're
it
a
with
little
a single
further-
balloon from above and then try to go below, or you can do with the double balloon, which he's trying here. But you can do either one.
Okay, down.
But Art, in this stage now, I go to a more. Which wire do you go to? I mean, or
So
Mahmood, in
let's
this
go
stage,
with,
anyone?
Once I do this, I
Yes.
take I usually the wires are all dinged up, so I try to switch to a fresh 014
Yes.
hydrophilic wire.
Yes.
And it usually just finds the
Right.
connection for you.
So that balloon actually breaks the step between the two, and then you take a hydrophilic wire to find the dissection plane. Sai, I know you love that one wire. I forgot you told me that you love it. It finds the plane every
Let's
time.
get some new
The,
command.
the Glidewire Gold is it's an 018 wire, but it is like a heat-seeking missile for the true limit.
Command
So.
DS014 ready.
It's
All right,
a very good
we're
wire.
gonna do one
Finds
at a
its
time.
channel
Let me
very
do
well.
mine
Yeah.
first.
And you'll hear us talk about a lot of wires, but in your
Okay.
practices, you need to choose one or two wires that you're very comfortable with, because everybody here
Now you
works
go
in
down.
institutions or bigger places, so we have more of the wires on the shelf. So always find one or two wires that you feel really comfortable with.
14. All right, now. All right, up. I'm just go up two. But we were going up one at a time each, and then up both.
We have to up-
Chris, you're a 4 millimeter from above.
Yes, and
And,
again, we go ahead and 3.5 from below. We can
Okay.
change that too.
Yeah.
Now the question here. Let's see. I'm going to
We
slowly
could probably
pull
try
the
to pull
top.
back your balloon and see if we find some.
Yep.
Yeah.
All right. Now the only question is whether to change out for this binged up wire or not from below. And that's not helped us
No.
yet.
Mm.
Okay, so I'll leave that wire and I'll just pull the other balloon back. Although I may change out wires here, as you said. Let's do this first. Let's pull this balloon back. If I back this back just a hair, back that carefully because I'm not that tall. Just back it carefully. Yep, come back a little more.
Yeah.
Okay, perfect. Just stop there. Okay, we have the torque run here, please.
So yesterday, George demonstrated this the spinner catheter. Have you had any experience with that? Anyone in the panel been these type of tough lesions?
Yeah.
Art, have you tried the spinner catheter?
No, I've seen him use it. I think the thing that spins for you.
Yeah, he
it's-
crossed the
yeah.
iliac with it
It's
beautifully. It
one of
was very
Fuzzy's
interesting.
devices. I think it's great. I do that anyway with my hands.
Exactly.
But, I have some partners
you
that
go.
never. Yeah, you're across.
I
Looks
think we
like
just
you're
got in
through
there,
Chris.
guys.
Yeah.
I think it
So I have some partners that the wire action is so dead. I'm like, you got to twirl constantly. So
Yeah, I think we're-
for those guys, I think it would be helpful.
Yeah, exactly.
Looks like he's across here.
Yeah.
I think just you're talking about the spinning. I didn't have a spinning wire, but I started to spin my hand just in melody here. So I'm not positive yet, quite honestly, but it sure looked like it went pretty well. So let's do this. Let's take our.
balloons are
Let's take. If you'll come hold the sheet for me, and then we'll take our 018 quick cross from above. All right, ready? Got wire? Fluoroform, if you would. The nice thing about
I
me
think
being
it's
short, I have a much taller, better assistant here. I can't possibly stretch here. I'd pull a groin like all my Steelers have. Thanks.
So everybody saw that he was able to cross once the balloon. We're very confident. I think he's in. Let's see.
I love the word "very." When
Lots of faith.
when Sahil says I'm in, and you say "very," I feel very good about things. So let's take our 135.018 Navracross, nice and wet.
So I think
Sahil later.
No, Chris, I was
we-
just going to say that what I was going to tell the audience is very important, even though if you're very confident, to always check your position before you do work. I mean, you could have popped into a vein, you could have been side by side subintimal, anything could happen. So always, check your position and then go ahead and then do your work, even if you feel confident.
Yep. PK, those are great points. That and Art's point late. The last thing you want to do is hurt some. I'd rather come back and do it another day than as Art said, with the balloons in different planes, or as you say, if I'm in a venous space or creating a big fistula, that's not helping anybody. And So you got wire real tight? Okay. All right, let's see about your very confidence here.
So just to mention a point, he crossed antigrade this time, which is good, and he can decide whether he wants to exteriorize his wire just to have, the traction to pass stuff through the calcium, which he may not need to do. But most of the time, I find we cross retrograde. And when you cross retrograde, the question is, how do you exteriorize your wire and so on and so forth? Maybe we can talk about that briefly.
Where is our...
Yeah, I mean, so do you use a quick capture art, or do you just snare? Or if you're really good, you can wire the catheter
back
from
but
above.
leave the wire.
Yeah.
That's just showing off, I think.
So typically, you use angled catheter, angled wire. You try to get it into the catheter,
Keep coming.
and then get into your sheath. But then you have that valve on the back of the sheath. So what I do is I usually take my short sheath that I started the case with, usually a 5 French. I stick it through the back of my 6 or 7 French sheath on the back. Just put the sheath into the valve. I put saline through the system so I can see it through angiographically, and then when the wire comes through, it usually goes right into that sheath through the valve, and I take that sheath out, and the wire's there. Then I have both wires, and then I pass the support catheter all the way through until I have the hypo tube out, and then I reverse the wire.
That's great.
I love it. So I want to show you something. As Alexis pulled the balloon back here, I want to notice the happy interaction between the balloon and that wire.
Yes.
It made me smile, y'all.
That's very real.
That was awesome.
All right, so now let's. Now I'm not so happy that this wire.
In a
I
different
may have
plane.
smiled prematurely because those wires are not as close as they should be. Okay.
That was what Mahmoud was saying with all those collaterals.
Yeah, I wonder if you're in a branch.
Probably in a
Yeah.
different
So do me a
branch.
favor, back that balloon out a little bit, and let's just bring your
picture
balloon
of
back a
the-
little bit.
Yeah.
Yep. All right. Now let me bring the catheter back a little bit and try to, and then if not, we'll take a picture and see. The good thing, I try to check my hands once a day for fractures. You can see them here. I have passed it every time. That
There you
looks
go.
better. And you're right. So we just had to go and change our angle and get down there. Okay. This is easy.
Wonderful demonstration, Chris.
Yeah, it's amazing.
Thank you. Now, let's think of, let's get our shockwave stuff open. I'm sorry. I love you, man. Our CSI guys
would you
here.
Iris
Just,
this?
it's a good question. Let's, we have Iris ready. So let's have a 5x60 shockwave.
Chris, we saw what was going on. Just wanted to talk to you and see where you're at.
All right, let's
Could
do
you-
me
with
a
the
favor.
IVUS?
Can you show the IVUS images, please, for them?
There it is.
All right. Are you seeing those? Okay.
Yep.
So you can see that we're going through and through there, and we're pretty much intraluminal. There's obviously a lot of calcium. But Nick, towards your point, now it's not as big. Usually, Nick, I'm a believer in you that, man, bigger, it's bigger than what you see. And I kept waiting for the Shamus theory to come to light, and it's the Metzger theory as well. It is not the biggest artery we'll ever deal with. Okay. Now, as you all know with shockwave, you really want to use at least 1-to-1 therapy. And so we had chosen already a 5. Now, I'm probably not going to go much higher than one atmosphere. Let me just put it that way. So we want to go, I'm using our initial pictures to find out exactly where we think we want to be, because I don't want to go too far downstream. So let's go ahead and do our roadmap, and we'll come back to 8.
Yeah, that's what I was going to ask you. Like, how far down are you going to start shock waving from? How'd you make that decision, Chris?
And I tell you what, as you know very well, PK, you're one of the big proponents of this as well. This is why for every case we do, there will be a ruler on before we start, okay? Because you get in there and you think, my goodness, where should I be? And, we have a great idea of exactly what it'd be. And we go back to the ruler rather than you and I guessing together and say, oh, it could be there, it could be there. So we're going to go with, let's see, 8 is where we want to be. And as you know, there's a distal end of the balloon there that doesn't have emitters. The first emitter's a little bit in that you can see there.
Right.
All right. So let's go up. We're going to go just to 1. I'll go to 1 atmosphere. Ready? Or you go to 1 atmosphere. You go ahead up to 1. So she's going to go to 1 atmosphere. And it really takes a physician to push the button. I'm kidding. Obviously, very much kidding. And they're all snickering at my silliness because
may I ask you what size balloon did you choose? And
yeah, it's a 5 by 60.
Okay.
Maybe a little bit aggressive, quite honestly. But the nice thing, I do believe that with the Supera interwoven stent, we have a bailout reasonable, in fact, not more than reasonable, very good option. I'll ask the panel what they would do. Would you use a drug-coated balloon? If you're going to Supera this, would you still DCB it to give you, because it's a smaller vessel, does DCB add, come on, turn it on, folks. You got to turn the green button.
Mahmood, why don't you answer that one?
Oh yeah, definitely.
Yeah.
There, mechanical support and all of that are one thing, but to prevent restenosis, we're going to have to go to pharmacologic treatment. And yes, I would use DCB followed by Supera.
Anybody wouldn't?
Okay. Shane.
I don't know if I'm not up on the latest data. I mean, Supera's got really good patency rates on its own. In a 5.56, I probably wouldn't normally, but on the smaller side, I might. But again, I don't know if there's data to support that. The other thing I want to mention is that given the size, I mean, just because you're using shockwave at the reentry doesn't mean you can't use CSI like infrapop, the distal pop, or even the distal SFA where you didn't really go subintimal. You can still use CSI.
Yeah,
do the normal things, right?
IVUS-wise, I thought there were areas 100% you could, but it's just the incremental cost of the procedure and what you're going to keep getting. I think that's the only issue. Yeah. But there is reimbursement associated with CSI, unlike with Shockwave. So I think there is. You can argue for both.
The balloon.
Sahil, you talked a lot about all the below knee technology seems to be sirolimus. I know Alok was here yesterday talking about why. I'm just curious on your opinion. Do you think it has to be scaffolding below the knee? Or do you think there is a role for drug-coated balloons? I skipped Marianne's lecture just for the sake of time.
No, I think that there probably is biological efficacy with taxanes. We just don't have the dosing figured out right. I think the vessels are different, and above and below knee are probably going to need different dosing. And we haven't figured that out. We have signals of efficacy with paclitaxel devices, but we don't have anyone that's really shown that it's successful. And I think it's for that reason that we're enthusiastically, embracing the Limus agents.
Yeah, but I got to tell you, one of my biggest disappointments was Jihad and his team worked so hard on the below knee trial, and the fact that we know it wasn't like earth shattering, but definitely there was an option that could have been given to our patients. And I know I spoke on behalf of it, and I know a lot of you guys did as well. Do you believe that the FDA or the panel is very, very, very strict in terms of their outcomes they're looking for? And do you think that was a fair result? I mean, I'm curious on your thoughts.
I think, it's hard to comment about what's already been legislated, but I think that
no, you can always comment.
I think the challenge really is identifying the best endpoint to design a trial that will show that we can win. I think it's going to have to be a clinical endpoint because that's where you derive value for these patients. And so that's why the limb salvage is so important.
But it's a very difficult endpoint.
The patency is really where we win. The truth is that these patients will have recurrent critical limb ischemia if they lose patency.
Sure.
And so it may well be that longer term follow-up is what's necessary to show a demonstrable win that's going to convince both the regulators and the payers.
But the worry I have with that side is that, a lot of times, we're great at revascularization and the teams aren't available for the wound care, and it's very rare that you get a true center that has everything. And I think that's the unfair part of it. I mean, I think the technology works, but we need so much more than in the coronaries because it's a little different, and I think that's the problem. The standards aren't set, like you said very clearly. The outcomes aren't set. I know Bill Gray always talks about that there's no real, how can you say, standard that we all should be able to follow for these trials. But so Chris,
PK, I just want to comment real quickly. I think you just said beautiful words of wisdom, PK. You can always comment.
I think truer words have never been spoken.
Yeah.
It's
Right under
probably
pizza.
growing up in Brooklyn. You know, we always have an opinion, and you know what they say about opinions, right?
Yeah, I do, but we won't say it on live
No,
because
no,
somebody
never,
will cancel me.
Never.
All right. So, PK, keep me up to date on time and lectures. I'm sorry,
was
we
just going
take
to
a
say,
little longer.
so Chris, as you work, why don't you tell us how you're going to finish? Because we're going to have to break
Yep.
away. We'll come back to see how you did. Just tell me what
Okay.
your final plan. Maybe after your shock waving, you take a picture, and then we break away, and then we'll go to the next series of lectures and cases, and we'll come back to you.
Perfect. Yep, but I appreciate that. So what we're going to do, I'm going to do a couple more shockwaves, one more after this, and then I'm going to give you an angiogram. And then we'll use that angiogram to help us a little bit, meaning that depending on how much dissection or not dissection will really help. Otherwise, we'll go to drug-coated balloon technology, down please, and then see how it looks. If it looks pristine after shockwave and DCB, then we're done because it's a smaller vessel. If not, we'll prep it a little bit higher, go up please, and probably put Supera interwoven stents after the DCB, because I do think, I agree with the comments made earlier, I agree with the comments earlier that for 6.0 Supera, the patency is phenomenal. You don't need it. But if you get down in the 5 range, that's a different animal. And so we'll try to make the vessel a 5.5 and put a 5.5 Supera, but we'll still add DCB to it. So let's do this. Let's get this out, PK, and take a picture. Hopefully it's a happy picture.
Yep.
And then we'll tell you what we're going to do, and then we'll try to get you final angiograms when we come back to you here in a moment. Calm down,
Absolutely.
please.
I just wanted to ask the panel, DCB and calcium. Is anybody staying away in calcified lesions with drug-coated balloons?
No, you just have to prep more aggressively.
Exactly.
So you could DCB the whole segment and probably do a spot stenting or wherever you find
So
it.
you just take this
Well,
out.
it's interesting, you know, because that was going to be my next question. When do you choose to stent the dissections in DCB? And I guess the true answer is we don't know. But the point is, I mean, in your practices, I mean, we all obviously do things in our practice. Are you looking only for flow limitation when you guys stent the DCB dissections?
Angiographically, anything D and higher. If
Okay.
you're reading the NHL by IVUS, anything that would
Get,
be a
nitro.
flap of over 180 degree.
Wow, so you do IVUS, huh?
If I IVUS it and I see anything over 180 degree, I'm not really happy.
Wow, that's great. Well, you
It's
definitely
worth a
shown
while.
that.
Okay.
Okay.
And a lot of times these vessels will have recoil as well because of the calcification. So you probably
Okay.
might need scaffold right there just to make sure the patency is there. After so much hard work, you leave it down,
Stick a
you might
picture.
shut down again.
All right.
All right, smile, hold your tongue to the left. All right. So we've got more work to do, I think. But I honestly think we're making some progress. That's
Yeah.
pretty good.
That's amazing.
So we're going to go ahead, take a few pictures, and again, we'll DCB and then use decision about scaffolding after that. And Sahil, you'll be very happy to know, my friend, one of ours that we were going to do today was a life BTK. Guess what? He's not going to be a live case, so he is going to be a life BTK. So add one, Lord willing, to your the numbers later today.
I'll buy you a beer next time I see you, Chris. Thanks.
Well,
Hey, wait a
Chris,
minute, we got a lot of witnesses on that beer thing, Sahil.
congratulations on a great live case. Thank you so much, and we'll see you very soon. Thank you.
Great, thank you all.
Great job, Ed.
Can we go back and show the final pictures that we had before, please? Let's get ready with our shockwave, or I'm sorry, 2.5 balloon. All right, so that's our drug-coated balloon. Remember, we left you with a shockwave. This was a long drug-coated balloon, 200 millimeter balloon for long inflation at 12 atmospheres, about 5 minutes. Okay, next. And honestly, folks, you remember what we were dealing with. It doesn't look bad. And people could go either way, but there is clearly, I think, a little dissection there. We IVUS that real quickly. I won't show you for time. And next picture, please. So, but I mean, all in all, from what we started with, for those of you that were with us this morning, going through cart, up, down, calcified, and so on, pretty good. Now let's go to the final picture. We chose to hit that a little harder and put Supera interwoven stents in. So if you will go back to the pictures after the Supera stents, please, our final pictures, and then we'll show our runoff. So there's the proximal, and show us the distal, please. All right, please, let's show the trifurcation. I'm in the other room, so I'm trying to navigate from over here. There we go. Okay, and then show the final runoff, if you will. Remember, we had anterior tibial axis. Here's our final runoff. And again, she had a big wound, nice and open through there. Very good runoff all the way down to the foot. No extravasation, simply manual pressure there. So I wanted to give you that update.